I'm Joyce Harper, Professor of Human Genetics and Embryology at the Institute for Women's Health in University College London, and I'm making these vlogs as part of the network called Global Women Connected. And today I want to talk to you about new techniques that are being offered for IVF patients. Worldwide, there are many techniques that are being offered, and almost every week you'll find some article about new technologies being developed in IVF. It really is muddling for anyone trying to have IVF treatment. There's so much conflicting data out there. It's a real minefield. So in this video I want to try and demystify some of these techniques. IVF is a multi-million-pound business. Most of the cycles done worldwide are done privately. So there really is a lot of incentive for scientists to try and improve the techniques and improve the success rates of IVF. When we're doing anything like this, we really need to do appropriate scientific research and really validate the technique. So if we're trying to compare two methods of IVF, say for one that we say is going to improve delivery rates, what we really need to do is the gold standard technique of the randomized controlled trial. So this is where there'll be a control group, which will be the standard treatment, and then the treatment group where the new technology will be used. And a randomized controlled trial with a good number of patients, normally for IVF it would be about 200 per arm, can then hopefully show us that this new technology is actually having a positive effect on delivery rates. So unfortunately there's much research that is being done and new techniques are being brought in without the proper validation, without the data from the randomized controlled trials. Sometimes a technique's been done for many years and then the data from the randomized controlled trials show that actually it's ineffective and it doesn't produce any positive effect for IVF patients. And some have actually shown a negative effect. So we really have to be very cautious about introducing new technology into the IVF lab, especially for patients with repeated implantation failure or repeated IVF failure, who are now really hoping to find some new technique that might give them hope in the future. So I'm going to go through in this vlog some of the new techniques that are being offered. And the first I want to talk about is one that recently was on a report on the Daily Mail talking about mild stimulation. The headline said £1,000 IVF cycle, and it actually took me quite a while to realise what they were talking about, but they were talking about mild stimulation. So in IVF there are many costs incurred, but one of the most expensive things is the fertility drugs that we use. So if we use mild stimulation, the theory is it's much cheaper because we're not spending so much on drugs. So the trouble with this technique is that we then produce fewer number of eggs, and there's a lot of data showing that the more eggs we produce, the better number of embryos that we have, and the embryologists have more selection to hopefully choose the embryo with the highest implantation potential, and so the greater success. So with mild stimulation, the data has shown that the technique is not as successful as a normal IVF cycle. So even though it's cheaper, your chances are to get the pregnancy rate similar to a normal IVF cycle, you'd have to go through multiple cycles. And going through multiple cycles can be very stressful for a patient, even if she's having milder stimulation and it's slightly cheaper. So we really need more data to determine if this technique is going to be viable, and maybe it might only be viable for a subset of patients. Another new technique is called endometrial biopsy. There's a technique where some of the endometrium, which is the lining of the womb, is removed and it's analysed for certain genes. And the expression of these genes are measured in something called the endometrial receptivity array test, the ERA. And there's some excellent data coming out now that's showing that for some patients we're not actually transferring the embryos at the right time. There's a very narrow implantation window. For the majority of people, we know when that is. It's predicted from their IVF cycle and from monitoring the endometrium. But it seems from this ERA test that in about 20% of patients we're actually transferring the embryos at the wrong time, and their gene expression that we can analyse from this test is showing us that the implantation window is either slightly earlier or slightly later than we thought. So this can help some patients. Again, we're gaining more evidence to see if this is going to be really useful and who it's going to be useful for. So staying with the endometrium, there's another technique a bit similar to the endometrial biopsy. This is called an endometrial scratch. And there's some evidence that scratching the endometrium in the cycle before the transfer cycle may give some immunological response which may help implantation in the next cycle. And it seems that this might be especially important for patients with repeated IVF failure. But again, we need further evidence to show whether this is effective. Now let's move to the IVF laboratory. There are numerous new technologies being developed for the IVF lab. It is now routine to transfer embryos, if they're available, at the blastocyst stage, which is day 5 of development. And the trouble with this technique is that the main data has shown that actually transferring embryos a bit earlier at the cleavage stage is actually just as effective, especially as more embryos are frozen if we've done cleavage stage transfer, normally done on day 2 or 3, because we freeze more embryos. So blastocyst transfer is quite routine and it's done for many patients, but we're still really looking at this data and seeing what's best for certain groups of patients. Another technique done in the IVF laboratory is called assisted hatching, and this is where a small hole is made in the shell surrounding the embryo, called the zona pellucida. And we think that in some patients maybe this shell is a bit hardened and it can't come out of this shell. It has to hatch from the zona pellucida to implant into the womb. So again, many units use this technique, but the evidence is very patchy and there's no compelling evidence to show which patients would benefit from assisted hatching. Now, I work on something called preimplantation genetic diagnosis, where we test the early embryo for genetic disease for certain patients at risk of genetic disease. Now, there's a variation of this technique called preimplantation genetic screening, and that's where we use the technique for IVF patients as an embryo selection mechanism. So what we do is we take 1 or 2 cells from the embryo, either at the cleavage stage on day 3 or a few more cells at the blastocyst stage on day 5, and we can analyse those cells to have a look at the chromosomes within the embryos. So this procedure has been done in thousands and thousands of cycles every year around the world, but at the moment studies are still underway to really show that this technique is a valid technique. There are new technologies coming out where we can look at all the chromosomes, even do something called next generation sequencing, but we still need randomised controlled trials to show which group of patients would benefit from using this procedure, PGS. Another new technique in the lab is time-lapse imaging. So when the embryologist is looking at embryos in the lab, they normally just do a check once a day. We don't want to keep moving the embryos in and out of the incubator. So normally they just are checked in the morning, their development's checked to see how it's getting on, and then we put the embryos back in the incubator. With time-lapse imaging, the embryos are stored in a special incubator with a time-lapse video, and images are taken every few minutes. So remotely, the embryologist can look at the videos and see how the embryo is developing over the whole time it's in culture, rather than just one check a day. And this is giving us some really amazing information about the embryo. What we're not quite sure about yet, if this is really going to help the embryologist choose which embryo to go back. We do see in a small amount of embryos some odd things happen in the development, which is not quite right. So we wouldn't transfer those embryos. But this certainly is a technique that's giving us lots of amazing information about early preimplantation development. But whether it improves IVF delivery rates is really still debatable. So it's almost 30 years since I've been working in IVF, and I've had IVF myself. My children were born from IVF. So I'm very aware of the new technologies that are offered to patients, and I'm very thoughtful about whether they should be offered and how risky these could be for patients. I've been involved in writing several papers on this topic, and in 2011 I co-authored a paper titled "When and How Should New Technology Be Brought into the IVF Laboratory?" And we are just about to submit a joint paper from the British Fertility Society and the Association of Clinical Embryologists about embryo selection mechanisms. So in that paper we talk about things like time-lapse and the PGS. If there are any other articles that you would like information about to be demystified involving fertility or any other women's health issues, then please get in contact either through the Global Women Connected Facebook page, or you can Google me, Joyce Harper, and it'll come up with my email. So there'll be more videos. The next video I want to do is going to be about the menopause, so I hope you look forward to seeing them. Thank you.